we were all able to and benefited with this guidance and advice. So we are extremely happy today to have him on the stage to address the quorum of doctors. And the moment we asked him, he was immediately accepted our invitation and said, this will be really beneficial to the medical fraternity. So thank you, sir, for your acceptance, immediate acceptance, and then we are extremely happy to have you here. And we felt you would be the right person to address this topic to the forum here, because there are many budding doctors, there are experienced doctors. This forum is a mixed forum with many people who wanted to know more and extend their service to the society. So welcome you, sir, and I thank all the participants for being here. And a small request before the session starts to the participants. We would request you to mention your name, mobile number, and your address on the chat box. Please do it without fail, so that for any kind of such future program, we will be able to get in touch with you, and then we will be able to share information accordingly. We are also recording this event, and this will be posted on YouTube for circulation of benefit of other participants who could not join due to various reasons. So, on behalf of Arogya Bharati Tamil Nadu, we welcome you, sir, and we really thank you very much for the acceptance once again. And then we will hand over the rest to you for your presentation and discussions. Thank you so much.
Yeah, good evening, everybody, and thanks to Mr. Janakiraman from Chakram Foundation and Arogya Bharati for the invitation today to speak to all of you about COVID and specifically about Omicron. I thought I will speak for about 20 to 25 minutes or so about the current scenario, and then we can open up for questions. Now, we are all quite comfortable and know much about the SARS coronavirus 2, which came out in Wuhan, China in 2019, in the December, or shall I say, the November of 2019. And we have already had 2 waves, and we are now going through the 3rd wave. And this is mainly because of the ability of the virus to keep changing. Now, this ability to change is called as mutation, and mutation refers to the change in the genetic code of the virus. And there are 2 types of viruses mainly. One is the DNA viruses, known as the deoxyribonucleic acid viruses, and the RNA viruses, which are the ribonucleic acid genetic structure-based viruses. And in general, the RNA viruses have a phenomenal ability to have mistakes in their reproduction. In other words, there is a fault in the reproduction which leads to changes in the genetic structure ever so often. And these mutations can lead to a different kind of viruses, and some of these viruses can have beneficial properties, either in terms of their ability to spread faster, their ability to evade the immune response, or the ability to evade the diagnostics which we commonly use. So this SARS coronavirus, which is an RNA virus like the flu virus and the HIV virus, has the ability of mutation. And ever since the virus came in, there have been over 400 or 500 different types of viruses which have mutated and evolved, out of which the WHO has recognized few major ones and have monitored them, what is known as the variants being monitored. And some of these viruses, or some of these mutated viruses, have special properties which come under the category of viruses of interest. If you have a virus of interest, a mutated virus, which has some evidence to say that it transmits faster or is able to evade the immune response of the diagnostics, they are labeled as variants of interest, or VOI. The alpha, beta, gamma, delta, the delta which caused the 2nd wave in India in April to June, July 2021. And the current Omicron are all variants of interest. So these mutated viruses, which are the same as coronaviruses, but slightly modified, one with the cap on, one with glasses on, one with coolers on. So these mutated viruses have special properties. And if I specifically talk about the Omicron, it has several mutations, almost 32 to 36 mutations in the spike protein. The spike is the outer protein which attaches to the receptor in the cells of the human body. So these are mutations which make the spike protein different. And there are Other than that, several other mutations. So totally about 60 mutations are seen in the Omicron virus. And this variant of interest, the Omicron, has the ability to transmit much better, which means it is 3 or 4 times more transmissible than the Delta virus. It is able to cause a different disease, though fortunately it is not a severe disease compared to Delta. The disease caused by Omicron is very mild. It has the potential to get away from the neutralization capacity of the human body. So if the body produces antibodies either after an infection or a vaccination, the Omicron is able to evade that. So even in people who are vaccinated, even in people who have had COVID in the past, Omicron can cause disease. And lastly, it can also evade the diagnostics. So sometimes diagnostics may be a problem. If the PCR kit does not have the, includes the spike antigen, the absence of spike antigen, which is, or the mutations which lead to difficulty in detecting the spike antigen, may cause a negative test. So these are the changes which we see in Omicron, and potentially these mutations may have significant impact, and that is why the variant of concern Omicron has been labeled a variant of concern. The next stage of variants is what is called the variants of high consequence. Fortunately, so far in the last 2 years, we have not come across any mutated viruses which we have labeled as a variant of high consequence. Now, this Omicron has certain clinical features which are quite similar to the Delta virus. So which means usually the incubation period we see in Omicron is shorter than the Delta. The Delta, it was seen, caused infection after exposure anywhere from 2 to 14 days after exposure, whereas the Omicron is believed to have a shorter incubation period. The average incubation period for Delta was about 4 to 5 days, but we believe Omicron can manifest symptoms even in 2 to 3 days time. Most people manifest symptoms. So the incubation is shorter. The disease may present with fever, sore throat, a scratchy throat, cold-like symptoms, runny nose, sneezing, body pain, and sometimes diarrhea and vomiting also. These symptoms can be mild in the elderly, but surprisingly, we've seen that in the younger people, the symptoms of Omicron, especially the fever, is very, very high grade. Now, Delta and the earlier viruses did not cause significant symptoms in the young. It was mainly in the elderly, it causes high fever, but Omicron causes high fever even in the young, 5 years old, 10 years old, 20-year-old children. I find that there is a high grade fever for 1 to 2 days, but fortunately, the infection comes down dramatically after 3 to 4 days. So the good thing about Omicron is even though the symptoms may be very marked in the initial period, they get better very fast. In 3 to 4 days time, they become free of symptoms in most situations. But some elderly people, some unvaccinated people, some people with comorbidities may have a persistent fever, or there is a possibility it may cause pneumonia and progress on to hospitalization also. Typically, the loss of smell, which was seen in the Delta and the earlier viruses, is somehow very rare or almost absent with the cases of Omicron. The diagnosis of Omicron is very similar compared to the earlier. We can diagnose it in 2 ways. One is using a rapid antigen test, which is a home-based kit. This looks at the antigen present in the virus, and Omicron is picked up in the rapid antigen test also. And the PCR test, which looks at the various proteins or antigens in the virus, the spike antigen, the envelope antigen, the nucleus, the RNA antigen, all of that is also useful in picking up the Omicron. But if the spike protein is absent, that is a strong indicator of the fact that it is Omicron. Now, earlier we thought if the spike antigen was absent, it was Omicron. If the spike protein was present, it is Delta. But now the Omicron has evolved a little bit more. Another lineage has come whereby some of the Omicrons do have the spike protein. So right now, using the RT-PCR test and detecting either the presence or absence of spike protein is not definitive of diagnosis of Omicron, and we need to do gene sequencing studies to confirm that it is Omicron. So this is the slight change which has happened in the last 2 to 3 weeks, that Omicron we thought we could detect by the absence of the spike protein, but current available lineage, which is increasing in spread, shows that it does get picked up, even though it is an Omicron and it is not Delta. The difference between the antigen test and the RT-PCR is that the antigen test requires about 10,000 to 1 lakh copies per ml of virus to be present in the secretions to be picked up, whereas the PCR test picks up even if there is 100,000 copies. So which means the PCR test is far more sensitive in picking up. A lot of times the antigen may be negative, but the PCR may become positive. So this is something new which we have recognized, and more people are resorting to the home-based kits because the disease is mild. They are not too keen to get tested and go through the problems of quarantine, other things. So they do the test antigen, and that could be one reason why actually it appears that we have already reached the peak and the cases are coming down. But I believe that we will reach the peak in the next few days, and probably by February 2nd or 3rd week, we will come down in the wave and things should get better. So that's what I hope at least. Now, the third aspect of the Omicron is the treatment of the infection. As I said, most of the cases which we see now are fortunately mild. Even if there is high-grade fever, the fever lasts about 3 to 4 days, and by 4th or the 5th day, most people are feeling remarkably better. So this is a very good sign. And in fact, I advise that if your symptoms improve in 3 to 4 days, you don't worry about it. But if symptoms persist in the form of persistent fever, worsening cough, tiredness, inability to eat or drink normally, that warrants seeing a doctor or a hospitalist to find out if you require any additional investigations or treatment. Now, the treatment is specific. There are 3 or 4 modalities of treatment available. You all would have heard of the monoclonal antibody cocktail. Now, this is still referred to as Trump's medicine because President Trump got it and recovered remarkably. This is the creation of antibodies in the laboratory and infusing that as an injection to a patient in the early part of the disease. It has to be given within 5 days so that it gives better outcomes. People can avoid hospitalization, avoid complications, avoid death, and it is believed this is a useful medicine. But unfortunately, the monoclonal antibodies currently available in India do not work against Omicron. So which means there is no point in considering or giving Omicron patients who are now having COVID, the monoclonal antibody cocktail. So that is out of the window right now. It is expensive, costs somewhere in the region of 70 to 80,000 for that infusion, and it doesn't work. The second treatment which we have is in India is there is a preparation of monoclonal antibodies available in the West called sotrovimab, which is not available in India, which is believed to be useful for Omicron. But what is available in India is no longer useful. There is another drug called Paxlovid. Now, Paxlovid is produced by Pfizer. It is actually a protease inhibitor, which is a combination of nirmatrelvir with ritonavir, which helps to block the replication of the virus. This is available in the West, but not yet available in India. The dose is twice a day for 5 days, but it may in near future come into India. And this is an option for mild, non-hospitalized patients with COVID, even Omicron or Delta. The third drug which is available is what is called as molnupiravir. Molnupiravir is available in India. The dose is 200 milligrams, 4 capsules, that is 800 milligrams twice a day for 5 days. Again, believed to decrease the chances of hospitalization, complications, and death. But unfortunately, the benefits are very, very small. The absolute reduction in risk to prevent hospitalization or severe infection is only about 3%. So molnupiravir, it is said, should be used only as a last resort and should not be used otherwise routinely. So in fact, the uses of molnupiravir has actually come down. The fourth drug, which has been found to be of use, is the drug known as remdesivir. You all would have been familiar with the term remdesivir, which was indicated in the earlier outbreaks during the waves as something which has to be given to people who developed a low oxygen or hypoxemia, and within 7 to 10 days of symptom onset. It was not found to be useful if they developed hypoxia after 10 days. So before 7 or at least before 10 days, those who had COVID, if they developed hypoxia, remdesivir was given as a course for 5 days, 200 milligrams on day 1, and then 100 milligrams once a day for another 4 days. There have been recent studies which are available that instead of using remdesivir in people who have developed hypoxemia, using remdesivir in the first 4 to 5 days, preferably again within 7 days in people who are otherwise stable without hypoxia, without requiring hospitalization, but who have a high risk of ending up with complications, that is elderly people, people with comorbidities, immunocompromised people. So in these people, if remdesivir is used for 3 days, 200 milligrams on day 1, and then 100 milligrams once a day for another 2 days. So 3 days treatment of remdesivir in the early part helps to prevent complications. So these are the 4 modalities which are available now, mainly for treating non-hospitalized patients with mild infection, even with Omicron. The usual algorithm is, the ideal one is Paxlovid, which is not available. The second option is Sotrovimab. Unfortunately, that is also available. Third is to use remdesivir 3-day dose for people who are not hypoxemic. And fourth is to use molnupiravir. So these are the 4 available options. The usual role of azithromycin, absolutely no role, because this is a viral infection. Azithromycin doesn't do anything. No role for any other antibiotics. Zinc, vitamin C, all make us feel good, but there is no medical evidence to say that they make any difference in the treatment of Omicron. The next question is, what about infection control? If I develop COVID, how long should I quarantine myself? Now, there is still a lot of confusion. The CDC in the USA says that 5 days quarantine, and then you can come out, but continue to wear mask for 5 more days. Now, England says 10 days quarantine, but if you do a lateral flow rapid antigen test on day 6 and day 7 and find it is negative, you can remove the isolation. Japan and France say 10 days of isolation. New Zealand says 10 days of isolation if you're vaccinated. If you're not vaccinated, it is 14 days. And the World Health Organization says 14 days isolation. And to make matters more complicated, the Indian Health Ministry says 7 days isolation from the day of testing. So when you have multiple recommendations, you know that nobody knows correctly what, but I think it will be perfectly safe to assume that 10 days is the maximum you will be infectious, usually about 8 to 9 days, and beyond that you are not infectious. And in general, we assume that a patient will test in 1 to 2 days after symptoms. So the Indian government's recommendation of 7 days after testing is very logical and rational. So we are looking at isolation of at least probably 7 to 10 days, which is perfectly fine. Omicron does not infect the lung cells in a significant manner. It is mainly in the respiratory tract, and probably it is believed that it is less infectious with regard to, shall I say, the presence of viruses in the respiratory tract is shorter than with Delta. So an incubation period of 5 to 7 days, or shall I say an quarantine period of 5 to 7 days should be adequate, and what India has given 7 days from the date of testing is, I think, quite logical and rational. What about the other people living in the house? The current ideal recommendations would be they also need to be quarantined, but if they develop symptoms, then do the test, or if they are not developing symptoms, do the test after 5 days. If they are positive, they need to continue quarantine. If they are negative, you can remove the quarantine. And the quarantine is for 7 days from the testing of the patient. So these are all the recommendations. Do you need to test people who are living in the house? No, the government has said only symptomatic people need to be tested. Routine testing of asymptomatic people who have been contacts of patients with COVID or Omicron need not be tested. So that is also clear. The other question is, when do you require a test? Suppose I have symptoms of, say, fever or sore throat or body pain. Do I need to test? Yes, if you have symptoms, wait for 1 or 2 days. But in those 1 or 2 days, make sure that you isolate yourself. So if you have persistent symptoms for 24 to 48 hours with upper respiratory symptoms in the form of sneezing, runny nose, rhinorrhea, blocked nose, body pains, fever, scratchy throat, diarrhea, or vomiting, which is persistent beyond 12 to 24 hours, a testing is necessary and you need to isolate yourself. Even before you confirm that it is COVID, it is recommended that you isolate yourself. The earlier studies showed that the secondary attack rate, or shall I say in the same household, if one person had COVID, the chances of the other person's developing COVID was somewhere in the region of about 9 to 14%. And currently with Omicron, it is higher. It is almost anywhere from 18 to 40%. So this is more infectious, believed to be probably getting close to the infectivity rate of chickenpox. In fact, today's papers, the Times, came up with the infectivity comparing that measles has the highest infectivity than chickenpox, and the Omicron is getting near that. whereas flu has an infectivity of only 2 compared to a infectivity rate, what is called as R0 of 18 for measles. SARS initially, COVID was about 3 to 4, and Omicron is, chickenpox is about 11 or 12, Omicron is closer to that. What do you do if you test positive? If I test positive, you don't need to panic. As I said, wait for 3 to 4 days. Generally, by 5th day, most symptoms improve. So if you feel significantly better in 4 to 5 days, you don't need to do anything further. Continue and complete the quarantine and move on. But if symptoms persist, you may need to get further testing. There is no role for a CT scan for any persons unless the treating physician feels that there is an indication, or if the person develops hypoxia. Otherwise, no need for testing. Few words about vaccination. It has been very clearly shown that whatever vaccine you take, whether it is Covaxin, Covishield, Moderna, Pfizer, complete dose, which is 2 for most of these vaccines, if it is taken, the chances of whichever variant we have seen so far, the severity, the need for hospitalization, complications and death are significantly lesser with 2 doses of vaccines. And that is why the Indian government is racing towards ensuring that everybody in India has completed their course of 2 doses. Is there a dose of booster necessary? There is still confusion about that. It is believed based on medical evidence that people over the age of 60 with comorbidities and people who are immunocompromised will benefit from a 3rd dose. Whether you call it booster, whether you call it precautionary dose, it doesn't matter. But a 3rd dose of vaccines does make a difference in these 2 populations. Is it required for other people? There is still no clear evidence. Vaccinations and a booster dose has shown to reduce the severity of infections in people who develop the infection after the booster compared to those who get the infection without the booster. It is also believed that vaccinations minimize the viral load in the throat and thereby decrease the chances of the infection spreading to others. So vaccines benefit not only in minimizing severity and complications, but also minimize the possibility of risk of transmission of infection. So vaccinations are currently strongly recommended, a booster dose for people who are elderly and people who are immunocompromised. But for others, we are still waiting for more evidence, but at least there is no harm in taking a booster we have seen. What booster? Whether we need to take the same vaccine or a vaccine from a different platform. Currently, most studies have been done only with the RNA vaccines. The Moderna and the Pfizer vaccines only have the maximum information available. Those who have had whichever vaccination, when they are boosted with these mRNA vaccines, the boosting effect is good. There is some evidence with Covishield stating that a 3rd dose of Covishield is taken that also improves your immune response. But conventionally, we know that when you boost with a vaccine from a different platform, what is called as a heterologous vaccine, makes the immune system react even better. So that is conventional wisdom, but we still don't have evidence with COVID to say that if you have had Covishield, take a Covaxin, or if you have had Covaxin, take a Covishield. So we don't have that evidence. And to decrease the logistical nightmare which people would get if India opened out heterologous dosing, it will cause a huge problem because predominantly we have only Covishield and Covaxin supplies are limited. And if all the people who have had Covishield are given the option to take Covaxin, we will run out of stocks very soon. So again, I agree with the government's plan to give only the same vaccine as a booster rather than a different vaccine. So whichever vaccine it is, the priority is to ensure that you get both doses, everybody, including children, and start with a booster or a precautionary dose in the high-risk individuals and immunocompromised before you look at vaccinating the rest of the country. So this is where we stand. The last few words. How is the future going to be? I'm not going to predict. I may speculate to say that in general, we have seen in the past diseases like this, which are respiratory virus and being transmitted. If there is an animal reservoir, they tend to become endemic with frequent increases, typically flu. Now, flu vaccine is seen in birds, flu infection is seen in birds, it is seen in mammals, it is seen in several species. Swine flu, bird flu, cattle flu, horse flu, everything is seen. So because there is an animal reservoir, we will never be able to eradicate flu. And every time it mutates and changes, we come up with a vaccine which has to be given every year. So will COVID also become like that? One group feels that it may, but because COVID doesn't have a specific animal reservoir, the SARS coronavirus has not been found to be present as a reservoir in any of the animal species. Since we don't have an animal reservoir, there is a strong possibility in another 2 to 3 years it may die off. Just like SARS and MERS earlier, the COVID also, after another couple of ripples, I don't think we'll get a massive wave like we had in the past. Minor ripples, maybe of minor mutated viruses we may get in the next couple of years, but hopefully it may slowly dwindle. So it may not remain endemic for long. It may die off in the next few years is what is strongly believed. And vaccination probably is the most important weapon. We have to make sure that we get rid of this faster and all stay healthy. So I'm going to stop here and open out for questions. If there is anything specific, I will take it from you.
Thank you very much, Doctor. That was really an enlightening session. In fact, you have covered upon in 3 different areas, including vaccinations. So as there are 111 people here, I would request whoever wish to put their questions one by one so that it saves the time of the doctor as well as, everybody can have a better clarity. Yeah, Mr. O.P. Tyagarajan, who has raised his hands, can, you can please ask your question, sir. Yes, sir. Mr. Tyagarajan. Can you unmute yourself and ask your question, sir?
Hello, sir. I am Dr. Jaykumar from Namakkal.
Yes, sir.
Please.
Yeah. Suppose in this scenario, we are getting a lot of patients in GP. Okay. So how to differentiate between the dengue and corona, sir?
Very practical
How
question,
do we
sir.
go about it? Yeah.
Dengue generally doesn't have any respiratory manifestations. Cough may be seen in malaria, cough may be seen in typhoid, but generally dengue doesn't have any respiratory involvement. So if anybody has either a runny nose, a blocked nose, sneezing, sore throat, and typically, as I said, COVID Omicron is associated with a scratchy throat, and a lot of people complain of severe throat pain, especially second, third days, they complain of severe pain. And I reiterate, there is no role for antibiotics in this. No role in giving azithromycin, no role in giving doxycycline, no role in giving coamoxiclav. So there is no role for antibiotics. This throat pain will last 1 or 2 days and disappear. Only paracetamol is recommended. Even if they bring up yellow phlegm, green phlegm, the risk of secondary infection is very, 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 very uncommon. So please avoid using antibiotics, though everybody feels that antibiotics make a difference. It is like saying you take antibiotics, you settle down in a week's time. If you don't take antibiotics, it may go on for 7 days. The same as that. So don't use antibiotics. Symptomatic treatment with antihistaminics and paracetamol only. So if they have respiratory symptom, think of COVID. If they don't have, dengue is a possibility.
Okay, sir. Thank you, sir. One more question. Actually, as you said, without the patients coming without respiratory symptoms, like dengue symptoms, severe body ache, pain in the small joints, and then distaste in the mouth, no respiratory symptoms at all, but they are getting positive of RT-PCR, sir. I've seen many patients.
A lot of people have asymptomatic infections or mild infections. They may have a little sore throat and disappear. They may have a little body pain and disappear. You cannot differentiate. But if they have respiratory symptoms, the possibility of COVID is high. Because Omicron in several vaccinated people is very mild. They may have a little body ache for a day and they may get better. So that doesn't help us.
Okay, sir. Thank you, sir. Thanks a lot.
Doctor, can I speak? Can you hear me, Doctor? I'm Tyagarajan.
Yes, yes.
Doctor, see, I have affected by COVID on 17th of this month.
Huh.
Okay, now, not much, it is mild. So I was taking just antibiotic. I did not take, only the 650 mg of paracetamol I took, and that's it. Now it is literally gone. But is it necessary to retest? Because I am planning to go abroad. So what is the procedure? Can you just highlight, Doctor?
there is no necessity to retest after an infection at any point in time. But if you're traveling abroad, the airlines, the country of, where you're going to, they will insist on doing a test. So it has to be done for travel purposes, not for the fact that whether to see whether you're cleared or not. In fact, if you have a positive test and after 10, 12 days you're traveling, and before travel, if you need a test and the test is negative, there is no questions asked. But if the test again comes positive, you can get a certificate from a doctor who has treated you to say that you had the infection 12 days ago, you've been quarantined, it's beyond 12 days, the test is still positive, but you're no longer infectious and you can travel. That is accepted.
Thank you, doctor. Thank you so much for the information. Thanks a lot.
Mr. Janikaran, there are some questions coming up in the chat box. Maybe I can, before others come on, I can just answer this.
I'll read out for you, sir. Yeah. There was a question from Dr. Duraraj Paramasivam. Good evening, everyone. Need to know the necessity of RT-PCR test for well-behaving kids before elective surgery. He's a surgeon. You wanted to have this clarification.
The question of pre-operative testing, whether it is kids or adults, is very controversial. Government has said no need to do tests. But having said that, there are situations where testing is probably necessary. One, the healthcare worker may feel that, the anesthetist may feel I'm putting myself at risk intubating a patient. So we need to do a test. The corollary is the patient may require, you are asking me to do the test, but if I'm having a surgery done, I'm going to be there. What is the possibility that the doctor doesn't have corona and I may get it from the doctor? So that has also been seen in private hospitals. The patients insisting that the doctor be tested so that they are clear that it is not. So that's a very, very controversial issue. But the only scientific evidence is in a situation where if the person is undergoing any major elective surgery, typically CABG, typically lung surgery, typically, major abdominal surgeries, which are elective, it has been shown that even people who may have asymptomatic COVID, the complication rate is higher. So for the patient's benefit, every patient should be treated as though they have COVID and precautions taken, the standard precautions like we do for HIV. So all doctors should assume that the patient may have, whether you test or not, but the testing is recommended in some situations where if they are having a major surgery done to prevent complications.
Can others please mute? Can others please mute? We are trying to mute you also.
So if to prevent the complications in the patient, then pre-operative testing is recommended, but otherwise no definitive reason.
Thank you, sir. One more question.
Sir, good evening, sir. Hello, sir. Good evening, sir.
Yeah.
I am Dr. K. Sendil. Sir, actually, people those who are already in chemotherapy, they will have that nephrotoxic drugs actually. So the giving remdesivir is advisable to them, sir?
Yeah, remdesivir is hepatotoxic. It's not specifically nephrotoxic. It is believed that if you have a raised creatinine, you may need to modify the dose of remdesivir. But having said that, we realized during the first 2 waves that since we give only a 5-day course, even people with raised creatinine, you can go ahead and give the normal dose. But you need to monitor the liver functions, maybe after 2nd or 3rd day to ensure that they are not running into hepatotoxicity.
Okay. So they are advisable to give remdesivir in the initial 3 to 5 days.
Indicated, yes, you can give it. Please remember that the preventive dose of 3-day remdesivir in people who are at high risk, the study was done at a time when people were not vaccinated. So we are not, I cannot say that that is definitely indicated, but it is an option. It is a reasonably safe option.
Okay, sir. Thank you, sir. Thank you.
Thank you for your question, sir. The next one is from Dr. Selvi. Does asymptomatic patients spread the disease?
Yes, asymptomatic patients can spread the disease, but it is believed that the viral load in the throat is much lower in people who are less symptomatic. So the risk of spreading is much, much lower, but theoretically they can spread.
Thank you, sir. The next question is from Dr. Vani. When to get a booster after a confirmed or suspected COVID?
I think the government has made it very clear, 3 months. It is believed that a natural infection or a vaccine induces antibodies which remain steady for 3 months, and after 3 months, it may fall off. So that is why the recommendation of the government saying that you wait for 3 months after an infection or suspected infection and then have it. before that came, my recommendation was you could wait 2 to 3 months before you take the vaccine. But for whatever reason, if you had COVID, you didn't know and you had the booster, will it be adverse for you? No, it is not adverse. But if you have the infection, waiting 3 months is perfectly fine.
Thank you, doctor, for the added information, which is really helpful. One more question. It's a specific case-specific question from a person name not mentioned. 59 years old, vaccinated with booster 1 week back with diabetes, cholesterol, and pacemaker on treatment. Yesterday, they had a severe fever. Today, not much, mild cough. Should we admit and start remdesivir?
I don't think, it depends. As I said, practical advice would be the chance that this is COVID is very high. Whether the vaccine was given 1 week ago or not, the presentation during times of an outbreak is strongly in favor of COVID. So assuming it is COVID, do you need to admit and do? I don't think so. I wait usually 4 to 5 days. If they, as you yourself said, after the first day, the patient is better on the second day. So I would wait another 2 to 3 days. If the person responds and settles down, nothing needs to be done. If after 3-4 days, they are still having issues, I would definitely consider remdesivir. Or if the patient is immunosuppressed in a significant way, I would consider remdesivir, but not a diabetic.
Thank you, doctor. The next question from Dr. Ilavar. In pre-op patients with COVID positive, should I wait for CRP to reduce before taking up for orthopedic surgery?
No, I think 7 to 10 days is reasonably good enough to do. Though the earlier recommendation is wait at least 14 to 21 days. If it is indicated, you can take it up after 10 days.
Thank you, doctor. The next question from Dr. Andal Nandagopal. A person who is infected with COVID, is reinfection possible?
Definitely possible. We have seen in this outbreak, most people have been vaccinated. Most people have had one attack of COVID and they still land up with infection. In fact, I have a colleague of mine whose son was tested positive on the 26th of December, became negative, retest for another reason. He had to do the test on the 10th of January. And now on the 22nd of January, he's tested positive again. This is the first case I'm seeing reinfection happening in a month's time. But Omicron, anything is possible. So it is possible. Very mild infection, but it is possible. Otherwise, you are generally protected for 3 months. But after 3 months, you can get an infection.
Thank you, doctor.
So I'm Dr. Jaykumar, sir. So what's your opinion about the England government's latest decision, the policies? What's your opinion about regarding this? No masks? Yeah.
I think the whole world will soon be following that. Whether it will be as relaxed or whether there'll be some restrictions, I don't know. But I'm looking at a time where very soon we'll have to accept this and just move on. These lockdowns, these, doesn't make much sense. Singapore government is already, in those lines. UK is starting. Whether we will get rid of masks, I'm not sure. But life will start moving normally without, all these restrictions. I think that will happen all over the world soon.
Thank you, sir.
Thank you, doctor. The next question is from Dr. K. Senthil Kumar. There is a considerable prevalence of ear block in recent COVID cases. How to handle the complications?
Treatment is purely symptomatic because, as I said, it affects the upper respiratory tract, throat, causes eustachian catarrh. So severe throat pain, severe ear pain, all this is possible. We give only decongestants, antihistaminic, that is all. And the good thing is generally 2 to 3 days it settles. I have used paracetamol, I've used NSAIDs. If necessary, they do well.
Thank you, doctor. A couple of next questions is one, will there be diarrhea associated with the symptom is one question.
Yeah, it is possible. We do get diarrhea and vomiting also.
Okay. And one more question from Mr. Arun Kumaran Arunagirinathan. I had COVID 6 days back, now better. When can I restart seeing OP patients?
Generally, as I said, 7 days. If you are free of fever for at least 3 days, beyond 7 days is okay. If you're very worried, 10 days is more than adequate for a mild infection.
Thank you, doctor. On a preventive note, there was one more question from Dr. Satya Kumar. Is N95 enough to prevent healthcare worker transmission to patients? He's meaning asymptomatic patients.
Yeah, if it is correctly applied. The problem with N95 is it should be fitted properly. Why do masks not foolproof? Because the surgical mask has holes here, through which the bacteria or the virus can enter. The N95 mask is more tight fitting. It fits around your nose. It sits like this, very close to the chin. So the escape of viruses through the sides is very, very low. So when you're using an N95, if it is properly fitted, unfortunately, most of these N95 is fashioned for the Western or the Caucasian face. The Asian face may not fit correctly, but if it fits correctly, you choose the right size and it fits correctly, that is the best.
Thank you, doctor. I also, recollect one of your presentation in a TV channel for public, which you said, people wearing a N95 mask in normal time and they want to cough, they remove the mask and cough. That's a behavioral pattern which you have also addressed earlier. Yeah, thank you, doctor. The next question is from Dr. Kavita Rajkumar. How virulent is the Omicron variant on pregnant patients, since we are referring patients to COVID care center for even asymptomatic positive? And there is also, and should we have to differentiate Omicron from Delta by mutation for genetic testing for general group of people? Is it necessary to diagnose which variant for treatment purpose?
Okay, I'll start from the bottom and way up. Is it necessary to diagnose which variant? Yes, if you're looking at using monoclonal antibodies, this will help to decide to use or not. Now, before that, is it possible to do the test? No. It is confirmed only by genetic sequencing, which is not commercially available. And even if you send it, it takes about 2 to 3 weeks to get the result, which makes no sense. So leave aside, you cannot do it. And it makes no difference because during the times of Omicron right now, almost 95 to close to 100% are all Omicron. So even when there is S deletion or there is no S deletion, take it as Omicron. Is it necessary to refer pregnant patients? Fortunately, we have seen Omicron in pregnant patients are very, very mild compared to Delta. I don't think it is mandatory, but the government says that even, all pregnant women should be admitted. So that's a government mandate. But fortunately, it's a very mild infection. I wouldn't worry too much about it.
Thank you, doctor. One more technical question towards this. S gene can be positive in Omicron. Is the data from India or it is from rest of the world?
Oh, no, it is from the West also. But there are studies in India showing that the Omicron with S gene, what is called the BA2, the other one is BA1, is the Omicron original one where there is S gene dropout. The BA2 is now picking up as the more dominant strain, which is increasing in numbers, and that has S antigen, and you cannot differentiate that from Delta. So it's difficult. There are further newer tests which are coming up which may help, but we'll have to wait and see.
Thank you, doctor. Mr. Bhaskar Krishnamurthy, have done second dose in April 2021 through booster dose is not eligible due to age. Does that mean we are now low immunity?
As I told you, the booster is more important for people over the age of 60. So if you are under the age of 60, I wouldn't worry too much. There is very little evidence that boosters make a difference under 60, but over 60, probably yes. So don't worry too much.
Thank you, doctor. The next question, Dr. Jaydur. Post-COVID patients having cough without wheeze for more than a week, not with cough syrup, antihistamine, role of steroid and nebulization.
It is anecdotal. If the cough is very, very troublesome, affecting daily life, yes, we have used steroids for a short 3-day course I've used. It is not recommended, but as I said, in severe cough, which is really troublesome, short course of steroids is acceptable.
Thank you. The next question from Ms. Sarojini and Dr. Andal Nandagopal. For patients with COPD and chronic respiratory diseases, any special precautions or treatment? Then vitamin C, zinc role in COVID infection.
Evidence, medical evidence, no role for vitamin C and zinc. For COPD, nothing. Ensure that they continue their regular medications, no special precautions or treatment.
Thank you. The next question from Dr. Venkatesan. How common is bradycardia with remdesivir? When should we consider treating it or stopping the drug?
Bradycardia has been noted in several patients, especially elderly patients who are given remdesivir. Actually, more than remdesivir, it is monoclonal antibodies which are associated with bradycardia. Remdesivir is not specifically associated with this thing. I think if they are monitored and if it is fine, I would probably stop it for some time and continue. Very rarely that we have had the necessity to stop.
Thank you, Doctor. Since there are about 34 still more questions, I'm clubbing 2 questions together from Dr. Vani Sri and Dr. Vishwanathan. Suppose if we currently have COVID after 2 doses, does the booster dose still have a role? The next question is, what are the chances of person having Omicron COVID home AG test kit negative?
Okay, if you have had COVID in 2 doses, 2 doses of vaccine and have COVID, that actually amounts to 3 doses, because it is shown that getting a natural infection is like getting a booster dose. If you're over the age of 60 or immunocompromised, I may consider, but not otherwise. I wouldn't worry. I'm not yet 60. I have not had my booster dose. My second dose was in February. I'm still a little. It's not like I'm against vaccines. I'm all for vaccines, but I wanted to get a little more clarity. I probably will be having my booster in the next few weeks. But just to tell you that you don't need to panic and get your boosters, all of you done. It's not that important.
Thank you, Doctor.
Getting everybody vaccinated with 2 doses is what is more important.
Sir, good evening, sir. Actually, what is the role of folic acid in the Omicron, sir?
Nothing. No role. You have said the next question was chances of Omicron in a home antigen kit is negative. Yes, possible. I told you the pickup rate, the sensitivity for RAT test is much lower. So PCR is more sensitive. So it is very much possible that the antigen test may be negative.
Noted, Doctor. The next question is, how long one should wait for chemotherapy if the patient had recent COVID infection?
I think if it is necessary, go ahead and give chemo. It all depends on the importance of the chemo. So I wouldn't wait. You can go ahead once he recovers.
So I'm again Dr. Jake Mercer. So one more question regarding the nebulization in the establishments, the hospital setups. So actually, first 2 ways, the government, they said, don't give nebulization in the hospital setups. Okay, in third wave, so there are so many hyperactive airway diseases and bronchial asthma cases. So I am working at the periphery, but those pediatricians from Namakkal, they just keep the nebulization in the hospital setup. And then they say, you just go to the nearby doctors and then you get the nebulization, 1 BD or 1 TDS. And all. So what's the opinion?
Nebulization is indicated, it has to be given. I think there is no, the only question
not for
is,
COVID patients, sir, for normal hyperactive.
Yeah. Anybody can have nebulization, sir. But if you are thinking of a patient who's having COVID requiring nebulization, because you can aerosolize the particles, the risk of spreading the infection is higher. So what I usually advise is the same thing for an open case of tuberculosis. So we just need to use our common sense. Do the nebulization. Don't do it inside a room, in a room where there is no ventilation.
Open air.
Open air, keep a fan to blow that away from the patient, away from the others. So it's simple common sense. So if it is needed, you can go ahead and do it, but do it in an open area. That's all.
So I know that, sir, what I do is I have some 5 to 6 nebulizer machines. What I used to do is, as I practice in the periphery, I have all the contacts. I used to rent it to the patients. I just give the nebu mask, take away, and then just keep nebulization at your home and then bring it back. I charge for that 25 rupees for a setup. Yeah.
Very good idea. So you need to innovate and make sure that it is safe. That's all.
Yeah, okay.
The next question from Dr. Alan Tom. How significant is an antibody titer? Does it change the outcome of decision of taking the vaccine? In the sense, it doesn't tell us whether or not it's natural antibodies or vaccine-associated antibodies.
No role for antibody checking at all, period.
From Dr. V.B. Narayanamurthy. Many people are not testing, taking the symptoms as they are. Do we have to insist if they are testing?
As long as you are able to isolate yourself to prevent transmission of infection and somebody monitors them to make sure that they are not deteriorating, I think that is acceptable during Omicron types, because we find most infections are mild.
The next questions. Role of cough syrup for protracted cough following COVID. Should we test all patients with fever and throat infection in the present time? Then can COVID patient, when they can donate blood?
Okay, so 3 questions here. The first question was role of cough syrup. Yes, whatever, symptomatic treatment even for several weeks is acceptable. Should we test all patients? No, this is my opinion. In a situation like this, where we know the disease is mild, where we know that the vaccinations, most people have been vaccinated, as long as you can monitor somebody, I don't insist on doing tests for everybody, but insist that they isolate themselves. That is more important. And 3, COVID patient, when can he donate blood? I think once he recovers after 2 weeks, 3 weeks, he can go ahead and donate blood.
Thank you. One person, Dr. Jayanti, I had COVID isolated for a week, have returned to work, but have cough sometimes troubling. This is common or any treatment can help?
It is common. We advise 3 treatments. Keep a flask of hot water and keep sipping. 2, use Vicks, Halls or Strepsils, some cough lozenge. And 3, any cough suppressant syrup. These are the 3 things we advise. And if it is intolerable, as I said, a short course of steroids, but that's not true. I wouldn't advise that.
Thank you, doctor. From Dr. Professor Manohar, if someone is symptomatic for 3 to 4 days, did not test, but family members is positive, should we take vaccine booster?
I would postpone it. I wouldn't be in a hurry to take it.
In spite of third booster, I saw an infection. What's your call on this, Dr. Satyakumar?
I have seen patients who have had 2 infections in the past and 4 vaccinations, 2 regular and 2 boosters. They go to the US and take 2 doses of Pfizer and come back and still have Omicron. So please remember, this Omicron is highly immune evasive. The good thing is it is very mild, but it does not prevent infection totally. So I'm not surprised at all.
Thank you, doctor. Next question from Dr. Vishwambar. Study shows that bromhexane works. What's your take on it, sir?
Not enough evidence. There are a lot of things which are going on, but you need significant, robust evidence to accept something and advocate. So I don't think we have come to that stage yet.
From Dr. Priya, correlation between CT value and RT-PCR test and severity?
0. I don't know how this came about. The CT value has no correlation whatsoever with clinical situation. It just tells us if the CT value is low, that there are higher number of particles. If the CT value is high, there are lower number of particles. This depends on the test methodology. This depends on when you do the test with onset of symptoms. It has no correlation with severity at all.
Thank you, doctor. Any other questions are there? You are free to ask. We have another.
So one more question, sir, from me, Dr. Jaykumar. So first 2 waves, they were government recommendations were like towards the zinc and then vitamin C, all those things. But in these 2022 guidelines, they omitted all those things. They recommended folic acid, ranitidine and all. So does it have some effect? I don't believe it.
Even when we framed the earlier guidelines, I said, let us not do it. But there was a lot of opposition. Very naturally, the doctors felt, sir, if you don't write any medicine, the patient will say, oh, what is this? You're not giving anything and we are suffering. Because that is the
yes, I know.
Public. Yeah. So that was why it was there. But now there is very clear evidence saying that nothing works. So okay. I think people are now more acceptable now.
Okay, sir. Thank you, sir. Thank you, sir.
Yeah. So there are a couple of more questions. Dr. Natesh Babu, geriatric patients already having neurological problems like Parkinson's or neurological problem, which vaccine is preferable?
Anything is preferable. So far, we have not seen there is any vaccine which is better or worse. So they can have it. We know that the benefits of the vaccines far outweigh the risks of the vaccine. So I would go ahead and give the vaccine, whatever.
Thank you, doctor. And Dr. Priya, what is your take on single dose of high vitamin D for treating COVID?
I have not heard about it. I don't know. I have not come across anything about the effect of vitamin D in COVID.
Noted, sir. And Dr. Lakshmi, one of my COVID positive patients, 6 days, have severe laryngitis, change in voice. What can be given? Not settled with antihistamine.
Voice rest. Nothing like Mauna Brother.
Okay.
Doctor, I'm Tyagarajan here. I have got just one question. My wife is down with COVID. Last 3-4 days, the temperature is just keeping below 100, but just swinging just below 100, 0.1, 0.2 like that. Should I continue with the paracetamol? That's it. Which should settle down within another 2-3 days?
If she's feeling better, that's what I ask everybody. Compared to 3 days ago, are you feeling better? And most people say yes. I will give paracetamol and continue.
Thank you, doctor. Thank you. Right.
I think the questions in the chat box are, what about children less than 15 years? I think it's a generic question. If there is specific, Dr. Satyakumar can also address.
Children less than 15 do have significant symptoms. I told you, 1 or 2 days of high fever and then they settle down, but they all do well. Fortunately, Omicron is a mild disease. So at the end of the day, unlike Delta, we find very, very little complications. But having said that, we have patients in the ICU on the ventilator, patients who have been vaccinated, patients who have had, confirmed Omicron, still ending up on the ventilator. So remember that the percentage of this is very, very small. But when, 100 million people get involved, definitely 1,000 people will get sick. So that is to be accepted.
Noted, sir.
Sir, I am Dr. Ramakrishnan, sir. What is the role of steroids, sir?
Steroids are indicated only if the patient is hypoxic. Otherwise, no role for steroids.
Okay, sir.
One question from Dr. Shyam Sundar. I mean, after a cranial surgery, how long a person can take a vaccine? What is the duration to take a vaccination?
Nothing specific. Once he recovers, which could be 2 weeks or 3 weeks, he can take.
Sir, good evening. It's a fantastic session, sir. I like to ask one thing. This dry cough thing is going on and on and on for more than 3 to 4 weeks now. Anything specific to be done, sir, for that?
I've already answered. I advise 3 things: hot water, cough lozenges, and cough suppressants. But I've also said that in some situations where it is very, very difficult for the patient, the early stage, especially after 10 days or 2 weeks, they've recovered, but they are the same. I suggest a short course of 2 or 3 days of steroids, but I don't recommend this as a routine. It is only in selected cases. Otherwise, if it's getting better, reassure the patients, they all do well.
Thank you so much, doctor. One more question from Dr. Shyam Sundar. Patient with history of coagulopathy issues acutely says cerebrosinuses venous thrombosis. Is vaccine better than Covishield?
Is Covaxin better than Covishield? Nothing specific so far. There is anecdotal information saying that Covishield has been associated with an increased risk of clotting episodes. But that is only that one, what is called as VIPIT, vaccine-induced idiopathic, VIPIT, vaccine-induced prothrombotic idiopathic thrombocytopenia, where there is clotting associated with thrombocytopenia, only that entity, but otherwise no specific risk attributed. They can take whichever vaccine they want.
And
so I'm Dr. Jaykumar, sir. So it's not a question, it's my suggestion. Just because of the seasonal, they think pani payide, it's a very cold climate. So a lot of patients have this hyperactive airway disease or bronchial asthma, something like that. So many of our colleagues have asked about the cough, prolonging cough. So many of our colleagues, they don't place the stent, they don't touch the patient. So in my experience, but with all SOPs followed, I just keep the stent on the chest. The patients coming repeatedly complaining of cough. When you keep the stent, you can hear the wheezing, or what you call bronchi. Okay, in that case, then we have to go for as the protocol, steroids and all those things. Then
I agree with you. I agree with you 100%. Without inpatients, I examine even COVID patients if it is indicated, as you say. Yeah. So if there is persistent cough, I don't think you can advise anything before you put your stent on the patient's chest.
Yeah,
so
yeah, of course.
What you said is perfectly correct.
Yes, sir.
And what I do is, you turn them and listen to the back of their chest. You don't need to go in front of them. I ask them
either by side or from the back. Yeah.
So definitely you have to do that.
Yes, sir. Thank you, sir.
Thank you, sir.
Can I ask a question? I hope you can hear me.
Yes.
I'm Dr. Praveen Agarwal, physician from Apollo Alvarpet and Fortis Malar.
Yes, sir.
What is the role of monitoring D-dimer and CRP, and especially now in this season with Omicron in a high-risk individual? Is it necessary to monitor, especially if they are clinically stable?
No, there is no role to monitor at all. I don't advise routine monitoring at all.
And Doctor, I'm really thankful for the lecture, what we have heard. You have so enlightened us so much that, now we are in a better position to understand this Omicron. We have also, we have 5 of us in the house, me, my wife, my daughter-in-law, my son, all 5 of us have gone through this in the last 20 days. I am a physician, my wife is a gynecologist. Luckily, all of us have almost recovered. So, and your lecture has actually hit the nail, exactly what we have gone through. We have had very comparatively mild symptoms. I am 65, my wife is 61. So we have almost recovered, and we are now, I am now more, encouraged now to go back to my practice the way you have told us that you can start going after about 10 days of isolation and all that. I just want to know, to close this session, what is the future schedule of vaccination for COVID in the future?
Anybody's guess, sir. As of now, we need 2 doses, and probably over 60 and immunocompromised need definitely a booster after 9 months. I think slowly the entire population will get a 3rd dose booster. But I'm not sure whether this is going to become an annual affair or the COVID will die down in another 1 or 2 years. We have to wait and see. COVID is
that's like you have taken your second dose in February 2021. I have also taken my second dose in February 2021.
No, you have got your third dose, sir.
But though I am more than 60, I am 65. So
you can wait another 3 months for the booster.
Yeah. So thanks a lot. Thanks a lot.
So, thank you all. I think we have it is very difficult to cut short this session. Still, there are a couple of questions. With this, we will close it. One, what about a cocktail therapy for COVID? And another one, cross-vaccination benefits. So,
cocktail therapy, I said that no, currently with Omicron, what is available in India doesn't work. We need to get Sotrovimab, which is not yet available here. And cross-vaccination, as I told you, theoretically, cross-vaccination probably is better, but with COVID, we don't have evidence. And for logistic reasons, the third dose of the same vaccine is better, and that is what is recommended, and I think that is perfectly fine.
Thank you, doctor. In fact, there are many generic questions like, since you being an visible almighty in the field of infectious diseases, many people have asked, what is the situation of COVID throughout for the next generation? There are some more questions like this. Like, I know you will answer them in the upcoming sessions in future. I also recollect one of you are saying in a forum where you said, there are several methods like government bringing down the COVID to a control. Likewise, you also said, we will be happy when we see the last patient with the COVID symptom. That's the end for the disease. So let's pray, and with all your efforts and, with all the doctors' cooperation, the human race is going to really survive and come better. And it was really enlightening session, sir, and we never expected it. And for the benefit of audience, I wish to convey, whenever there is a social cause, some program is being conducted, and doctor will be the first person to give us session. And that's how we have, taken his presentations across the world to many people in gaining knowledge and then giving them a light. Thank you so much, sir. On behalf of Arogya Bharati, I would wish to thank you personally. And it was really a wonderful session. I hope many of them, there are about 138 participants till the last. I mean, they all got benefited with almost each questions from their side, sir. Thank you so much, sir.
Thank you. Thank you.
Thank you, doctor.
Thank you, sir.
Last question, doctor. One question. Which one do you treat when you test the patient or the asymptomatic patient when she or he starts having problem?
I am not sure I understand you, sir, but when you treat...
See, I'll just give you an example. My wife was tested yesterday, but she was having problem from 17th of January. But yesterday when we tested, she got result as positive. So which one I should consider, yesterday or from 17th?
Consider for what?
For the treatment. How long it will stay?
I mean isolation.
Yes.
Isolation at present is 7 days from the date of testing and at least 10 days from the onset of illness. If the fever settles and you are free of fever for 72 hours, that is the isolation.
Thank you so much, doctor. Thank you. Thank you.
Thank you all once again. Thank you, doctor.
Thanks a lot.
For an excellent session. Thank you.
Thank you, Jay.
Thank you, Dr. Hariharan. I really got benefited because of you. Thank you, Dr. Hariharan. I'm Dr. Karthik from Coimbatore.
Sir, whoever is quitting this, request you to please give in your information, name, phone number, and address details for us to communicate you back for the future programs like this. Please put it in the chat box before you leave.
Ma.
Vedagiri ji, namaste. Saravanan ji, namaste. Vedagiri ji, namaste.
அவர் 2 கார்டு கொடுத்தா வரும். சுண்டலா